afternoon. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities here at the UVA School of Medicine, and I'm happy to welcome all of you on this lovely spring day to our Medical Center Hour program. Today's program is entitled Our Bodies Ourselves, Reading the Written Female Body. Women of a certain age in the audience will remember this book. Perhaps with considerable fondness and maybe even with a little nostalgia. I was in graduate school when I bought this copy in 1973 for $2.95. This book was first published in this incarnation in 1973, but a couple of years earlier as a much more sort of loose leaf textbook by the Boston Women's Health Collective. Our Bodies Ourselves was a revelation to legions of readers. It was something quite unprecedented, an owner's manual for the female body at a time when medicine, male-dominated medicine, seemed society's chief authority on women's health and anatomy. Now in its 8th edition, this is the 35th anniversary edition, it grew to Our Bodies Ourselves remains an important and an empowering source of information for women about their bodies and their health. Our Medical Center Hour today inquires into the writing of Our Bodies Ourselves and the relationships that the book forged between the collective authors and their readers, and importantly, between the book's readers and their own bodies. We welcome today, on my immediate right, Susan Wells, Professor of English at Temple University in Philadelphia, whose current project is a rhetorical analysis of Our Bodies Ourselves in its various incarnations over the years, starting with the community education course that was developed in the late 1960s by the group of women that became the Boston Women's Health Collective. We also welcome 2 respondents. On my far right from UVA, Dr. Joanne Pinkerton, who's Professor of Obstetrics and Gynecology and Director of the Midlife Health Center here at the university. And from Charlottesville in the middle, Miriam Bender, a founder and the Chief Executive Officer of the nonprofit statewide health advocacy organization, Women's Health Virginia. Dr. Pinkerton and Ms. Bender will speak briefly after Professor Wells' presentation. You'll find some brief biographical sketches of each speaker in your handout. You'll also find in your handout 10 little myths about menopause, since, again, women of a certain age seem to be in the audience. How has Our Bodies Ourselves, something of the health politics movement in and of itself, changed how women understand their bodies and their lives? How women and girls now approach their health and their health care? How has the book's first generation of readers, baby boomers all, handled the aging of their bodies, their health decision-making, their health care? And what debts do women's health initiatives today and tomorrow, clinical programs and advocacy organizations alike, what debts do they owe this landmark text and its authors? And we'll find out some of that in this hour, and we'll hope we have time for questions and comments from all of you as well. Susan Wells, welcome. I'll put them on the screen. Good afternoon. Thank you for coming, and thanks, Marcia, for your kind and generous introduction. I'd also like to thank Joan Klein and the Historical Library of Medical School for their hospitality, and it is a great honor and pleasure to be at this distinguished event. Most members of this audience, well, about half of this audience, knows the story of Our Bodies Ourselves, which kind of coalesced at the 1969 May Female Liberation Conference at Emmanuel College in Boston, an event where twice as many women showed up as everybody thought would show up, where there was a workshop on women and their bodies, which was so intense and gratifying that everyone decided to meet again. Okay,
which could be the slogan for the 60s in certain places. And as this group continued to meet, they formed themselves as a group called the Doctors Group. They wanted to find a list of the doctors who they felt, because they took a survey, were good doctors for women. So they sent out a survey, and I've seen it. It's just a little Xerox page, and it talks about how, isolated women are one by one in the doctor's office, and how this would be a way to pool information. But they found that it was not that simple, because every survey that they got back that said, my doc, wonderful doc, love my doc, and they said, okay, we'll put this one on the list. 5 surveys later would come one that said, by all means avoid this doc, the very same doc, because this person is like totally mindless and gave me terrible care. So faced with this conundrum, the group decided that they would have to learn themselves how to sort out health information, how to manage their medical care. Since they were a very literate group, a very well-educated group, they kind of divided this up as if it was some strange amalgam of a graduate seminar and a consciousness-raising group. I'll take the no, nobody took the menopause chapter. It's unimaginable. I'll take the menstruation chapter. I'll take the sexuality chapter. I'll take the childbirth chapter. And I've already talked past my first slide. I'm sorry. There it is. And this group, which at the time was much, much looser, there in 1970, this group put together a series of papers. They then presented those papers, although they had papers, but they were really discussions, at a women's health course, which was first given at MIT that in the fall and winter of 1969 and 1970. Apparently about 200 women went to this course, and it was life-changing. People sat in a large lounge on tables, they lay on the floor, they interrupted the speakers, they talked about masturbation. Women who were in a karate class kept men from coming in. It was really fun. And many, many women who'd taken the course, which then was replicated in church basement after church basement in the Boston area over the next 2 years, asked if the notes for the course could be put together as a book. And of course they were. This is Women and Their Bodies, the very first edition of Our Bodies Ourselves, published in 1970. This book sold for 75 cents. It was bound in 4 parts and then stapled together so that it could be given out in 4 separate sessions of a Women and Health course. It was set with unjustified margins. Page numbers were hand-lettered in. There were no captions. Who could do that, you know? It was basically a homemade book. In 1971, a second version called Our Bodies, Ourselves, 4 words, was published. Both books were actually published by the New England Free Press, which was a movement publication house. Since Women and Their Bodies had been so successful, Our Bodies Ourselves could sell for 50 cents, because who could make a profit on this, right? And it sold some 270,000 copies. And given that the distribution was basically hand-to-hand and word of mouth, that was really, really remarkable. In 1973, the Red Book, which you've just seen, was published by Simon & Schuster, about a little more than double the size, $2.95, a pioneering contract that let the collective retain copyright and let them also handle overseas distribution, which has been an important venue for the book's dissemination. There have been expanding editions, translations, and adaptations up to, this is just a bigger version of what you've seen before, the 2005 edition, which is supplemented with a constantly updated website. The story of this book, and here you have the table and contents in the first page of the 1970 edition, with what I think is a picture of the Emmanuel Conference workshop. A hand-lettered table of contents. You can see that the margins were kind of done on a typewriter, and then the typewritten page was cut and pasted around the photograph, which meant this was put together at somebody's kitchen table. The success of this book, which has been read by 4.5 million women now, is really, as an early preface to the book put it, a good story. It's a story of a group of women who moved from ignorance to knowledge, educating each other and building a valuable institution as they went. This paper analyzes that work as a labor of constructing language and a struggle to understand the body and the disciplines that attend to it. I will begin by looking at how that language worked to sponsor investigations of the body, and then consider the discussions of the clitoris in the very first editions of the book. Nowhere were questions of representation more fraught than in the description of the clitoris. Nowhere was the collective's practice more inventive than in their continual recreation of that organ. I'm working from the assumption that we know the body, and especially we know our own bodies, through disciplines that are saturated with the desire. I mean, what do you expect? I'm an English professor. That's what we work with. And those desires for the collective included a desire for wholeness, for a particular object, for a particular localized experience, and for a particular kind of objectification. These desires were especially strong for members of the Boston Women's Health Book Collective, who had just discovered the importance of sex roles, of objectification, and stereotyping. They really valued images of the whole body, and they distrusted images that segmented or divided the body. Early in its history, the Boston Women's Health Book Collective was invited to put up an exhibit at a health fair in Boston, and they eagerly agreed they were going to bring their Raggedy Ann doll, which had a vulva, and it had a sign over it saying, "Raggedy Ann learns about herself." And then somebody suggested that they have a picture of many, many cervices. And I mean, think about how few people in the United States would make the plural of cervix cervices at that point. And they had a long debate over this, and they finally decided, no, we don't want to show women in parts. This seemed abhorrent and kind of crazy to them. Beginning with the third edition of Our Bodies Ourselves, the red-covered edition, the book included the lyrics to a song called Our Faces Belong to Our Bodies, a song which was composed by the It's All Right to Be a Woman Theater. And the song goes in part, and I won't sing it, for which you should be grateful. Our faces belong to our bodies. Our faces belong to our lives. Our faces are blunted. Our bodies are stunted. We cover our anger with smiles. Our love is changing our bodies. Our love is changing our lives. And apparently, at productions of the It's All Right to Be a Woman Theater, what happened was that as this song was sung, a woman was standing on stage and she would touch various body parts, but whenever she touched her breast or her genitals, a kind of kazooie, blatty sound would come, and she would kind of be warned off. And then finally at the end, the whole, this was the finale song, the whole cast and the whole audience would come on stage and sing the song with her. And that song, and in its performance, seemed to express to the collective something they wanted to say about women's bodies. This anthem can be read as an affirmation of bodily integrity. The oppressed body is transformed by struggle. Our bodies are changing, our love is changing our bodies, until it is completely identified with the face, the public self. This is really an intoxicating vision. Our bodies ourselves expressed this vision and supported it, but they couldn't do what they wanted to do, which was provide medical information without turning away from it. Because to provide medical information, they had to divide the body into parts and into systems and examine each one separately. And then on the third hand, the collector was really interested in women's experiences, fluid and mobile and changing. So you have these three simultaneous constraints. Show the whole body, show the body changing, concentrate and focus on parts, and provide reliable information about those parts. They were able to stabilize these contradictory impulses by organizing their story about the body as a narrative. And the narrative was a narrative of the reproductive life cycle, in which various body parts swim in and out of prominence and are alternately represented as bounded objects and as vectors of sensation. That narrative in the very first editions, as you can see from the table of contents, begins with the anatomy and physiology and goes through the sort of psychological and political material in sexuality and in some myths about women. Then there's a chapter on venereal disease, birth control, abortion, pregnancy, prepared childhood, postpartum, and that's it. Okay? That's the end of the reproductive life cycle in 1970. The chapter at the end on medical institutions was written by Lucy Candid, the only member of the collective to become a physician, and she had to leave right after the 71 edition because she was a medical student. Later, this narrative would expand. By 1973, there was a short chapter on menopause. By 1976, it was expanded. In the 2005 edition, there's a chapter on old age, which is finally admitted to exist. When the text opened, the speaker of our bodies ourselves knows the body, owns the body, is the body, and is completely at home in it. When the text opens to include the reader, as it often does in the anatomy chapter, that experience is presumably replicated in the mind of the person reading the book. This integration was presented as a remedy for a very different experience of the body that the collective recorded in the 1970 edition and described as disgust. And this is a fairly long quote. Nearly every physical experience we have as a woman is so alienating that we have been filled with extreme feelings of disgust and loathing for our own bodies. Every part of the body is an area of real or potential disgust to us. Faces, armpits, vaginas, buttocks, stomachs, breasts. The slightest so-called imperfection is a source of very private anxiety and fear that we dare not communicate to each other because we are taught to think we are the only ones who feel these things. And the objectified disgust we have for ourselves, we feel toward other women, and we are filled with disgust at the thought of her, parentheses, our, close parentheses, body, under the clothing, armpits, vagina, etc. This is a very frank avowal, and it's also really politically incorrect. By 1971, it would be distanced. By 1973, it would barely exist. It would be, we used to feel disgust for our bodies. And when I read it to Jane Pincus, a member of the collective, she just couldn't believe that was there. She said, really? That's odd. Is that possible? It was really a kind of borderline statement that could only be made at the very, very first moment of the collective's work. While the main argument of the text presented the female body as a universal privileged whole, in this passage, bodily experience reflected the speaker's disgust. The other woman is indeed just like me. We do share the same body. Both our bodies are objects of anxiety and fear. And this is kind of a crazy position. I mean, look at the pronouns in this passage. We think we are the only ones who feel these things. I mean, if you think about it, isolated shame is something that just can't be felt by a we. As soon as you've got a we, there can't be only ones, you know? It's a strange amalgamation happening in the language here. There can be no natural object that's designated as her, parentheses, our body. That just doesn't exist. Knowledge of the body is knowledge of socialized body, a source of anxiety and shame. The critical appraiser who finds flaws everywhere enacts not only her own body's distance from the ideal of beauty, but her own failure to achieve autonomy. And so the speaker of this passage feels bad because body parts are disgusting, but then she also feels worse because she's disgusted. You know, how is it that I feel this disgust? And it's a very tangled kind of mental state that this paragraph describes. And it's very appropriately named later in the text as the nowhere identity we have been forced to subsist on for so long. And so we might ask, since they're all... Who is it who is aware of feeling this disgust? What kind of subject is constructed in this complex report of a complex relation to the female body? Part of the answer is this speaker is someone who's aware of her self-disgust, looking at it, as it were, from outside. And that clears a little bit of space in which the speaker can look at the inside of the body. And looking at the inside of the body turned out to be quite liberating. We have no norms, or at least in 1970, the mass culture had no norms, for a nice liver or the right fallopian tubes. The interior of the body, at least for young and healthy women, is a region free of judgment. It could serve as a ground of positive universality. Another member of the collective, Miriam Hawley, said, "We discovered that women's bodies look different, but they all work the same." And it was that working the same that the collective wanted to elicit and make available to readers. While the conventional experience of the objectified body led to concealment and isolation, looking at the inside of the body encouraged a regime of self-care and bodily transformation. Communicating the results of these investigations opened new space in a refashioned public sphere where questions of health and medicine were no longer consigned to the privacy of the medical consulting room. Once the body is claimed as the full expression of the knowing subject and as an object of knowledge, both the self and the body are doubled. The self is the known object and also the vehicle of knowledge. The body is the objectified domain of knowledge and therefore emphatically not the knowing subject. Now, objectified was a very resonant word for second-wave feminists who considered sexualized or stereotyped images of women to be objectifying and part of constructing the nowhere identity. Images of body parts, particularly eroticized body parts such as breasts and legs, were held to be on their face objectifying and therefore wrong. Such divisions and objectifications are not mistakes or accidents. Although the collective projected an ideal of integration and autonomy, their own textual practice demonstrated that all understandings of the subject are split and doubled, and that split and doubling is a source of desire, action, and pleasure. And that splitting is really clear at the place where the collective talks about the clitoris. Okay. Now, at that point in the original paper, there was a long Lacanian piece, which I'm not doing, and you should all be grateful. In the 1971 New England Free Press edition of Our Bodies, Ourselves, the sexual organs in general and the clitoris in particular are presented as androgynous. In the first 20 pages of a text, you can find no fewer than 6 guideposts how to find your clitoris and what it will look like. And I'm putting one at random. The clitoris is homologous with the penis and has analogous functions of erection and orgasm. The hollow areas in the man's penis and in the woman's clitoris are called corpora cavernosa, literally hollow bodies. Like the penis, the clitoris is composed of shaft and glands. And here's a slide showing an image which has exactly the same message. Sex organs of fetus at 8 weeks when differentiation first occurs. And the idea is there's differentiation, but it's really basically the same organ. Notice also that this picture has a hand-drawn border and the photograph credit is just inked in. This is such a homemade book. Where is that? Okay. In these descriptions, the clitoris guarantees both androgyny and autonomy. It signifies that sexual difference is an illusion because the penis and the clitoris are the same. But also that women are radically different from men. It's not a penis, it's a clitoris. The clitoris defines women's autonomy. Because of the clitoris, our sexuality is not oriented to male satisfaction in intercourse. Because of the clitoris, we can express and explore our own sexuality. The clitoris is a sign of primal equivalence between men and women, of the difference of the knowing female subject, and of her sexual autonomy, an autonomy that is quite practically ensured by anatomical knowledge. The clitoris is therefore divided and contradictory in its gender coding. It is both male and female. This double coding economically mapped multiple understandings of gender on the new territories of the body. It cohered with feminist interests in androgyny, which were really characteristic of 1970, and by 1973 would be more or less gone from the women's movement. And it was a moment of androgyny. Investigating the clitoris was a first step in reclaiming anatomy as a rhetorical resource for the women's movement, just as history is a resource for movements of national and ethnic liberation. Both serve as records of oppression and as catalogs of strategies and practices of resistance. Women are encouraged to survey, investigate, and occupy the body. And here's a short quote. We emphasize that you take a mirror and examine yourself, touch yourself, smell yourself, even taste your own secretions. How many teenage girls went, ew, when they read that part? You are your body, and you are not obscene. What representation of the body is offered then by the 1971 Our Bodies Ourselves? It is a body deeply divided, split into the material abject ground of a contagious disgust, and the shifting location of that disgust in a knowing agent. It is a body experienced as a surface of zones of possible degradation. It is a body that is internally undifferentiated and unknown until you open the book. The text, when you open the book, you open the body. It maps the territory of internal organs and establishes correspondence to external palpable structures. The surface of the body is given over to ideology, oppression, and division. The interior is claimed for nature, liberation, universalizing knowledge. The palpating hand and the seeing eye belong to an agent of anatomical knowledge who will understand the unseen interior. The clitoris is presented in these early editions as an organ that connects the interior and exterior of the body. The collective assumed that for most readers, the clitoris would be as mysterious as, if far more interesting than, the spleen. Most readers of Our Bodies Ourselves would not have seen any image of the clitoris at all, since anatomy textbooks commonly did not show the organ, or they just left it unlabeled on diagrams. New research on the clitoral orgasm, that is new in 71, was evidence of, at once, that male-dominated professions in the health sciences were ignorant, and that a much better science would offer knowledge that would be really useful to women. The clitoris told all of these stories, and it told them efficaciously. Okay, now I'm going to go back to the slide of 73. Because in 1973 and in 1976, the clitoris told a completely different story. It changed dramatically. The chapter on anatomy and physiology was rewritten in 1976 by Esther Rome, a member of the collective who has since died. Here, the clitoris is, and more or less stayed the same from 76 to 2005, where it was again rewritten. That chapter is really one of the successes of the new book. Here, the clitoris is stationed at the border between the interior and the exterior of the body becomes more explicit. In this edition, there's no more disgust, or the disgust is something we used to feel and we don't anymore. Instead, there's anatomical knowledge. Until we began, this is a quote, to prepare the material for a course on women, many of us didn't know the names of parts of our anatomy. Up until maybe 1985, for the collective, knowledge of anatomy was naming of parts. And in the very first edition, they go bananas. Like if they have a Latin word that they know, like atritic follicle, they just salt it in there. I mean, they took pride in their understanding of terminology. Some of us, they said, had learned bits and pieces of information about specific body functions, menstruation, for example, but it was not permissible to find out too much. The taboos were strongest in the areas of reproduction and sex, which is why our book concentrates on them. Anatomical knowledge is knowledge of names, partitioning of bodily spaces that had been experienced as indeterminate and inchoate. The text invites the reader to move, to feel specific joints, to distinguish the inner and outer lips, to locate the vagina in relation to the anus, and finally to identify the clitoris. And very explicit directions. Lock the door. Get yourself a good light. Make sure you have some time. There's a staging of this investigation. A very literal form of self-knowledge, which is also a direct intervention into the lives of the readers. Whether you actually performed self-examination as you read the text, you could not help imagining self-examination as you read it. And the book's positioning of the reader as a philosophically detached investigator is enormously powerful. That investigator is a discoverer of new territories, the previously unknown and submerged provinces of the clitoris. In 1971, the clitoris was a ball of flesh. By 1976, it was a much more complicated and extensive organ, a system of interior and exterior structures that can be identified and manipulated. And this will be the last long quote from the book. Let the hood slide back over the glands of the clitoris. Extending from the hood up to the pubic symphysis, you can now feel a hardish, rubbery, movable cord right under the skin. It is sometimes sexually arousing if touched. This is the shaft of the clitoris. It is connected to the bone by a suspensory ligament. You cannot feel this ligament or the next few organs described, but they are all important in sexual arousal and orgasm. At the point where you can no longer feel the shaft of the clitoris, it divides into two parts, spreading out wishbone fashion but at a much wider angle to form the crura singular crus, the two anchoring wingtips which attach to the pelvic bones. The crura of the clitoris are about 3 inches long. From the fork of the shaft and the crura, and continuing down the sides of the vestibule are two bundles of erectile tissue called the bulbs of the vestibule. These, along with the whole clitoris and an extensive system of connecting veins throughout the pelvis, become firm and filled with blood, pelvic congestion, during sexual arousal. The reader has become the writer. The investigator has become fully identified with the object of investigation, so that even structures that cannot be seen or felt are located and understood. The territory of the genital organs has become animated with the events of arousal and orgasm. The clitoris of the 1976 edition is a very mobile organ. It distinguishes the body as feminine on its surface. There's no more, it's just like a penis. We're really androgynous. It's entirely sort of woman-centered, woman-identified. But a woman who wants to see the clitoris needs time, privacy, mirror, and a good light. Her inspection will teach her to divide the external organ into parts, but she will be encouraged not to limit her investigation to what she can see. She will find some of the interior portions of the clitoris by touching them and by being aroused, and in that act, she meets herself as both sexual object and sexual agent. Other, more subtle parts of the clitoris can be only appreciated indirectly from the text description, from its illustrations, or from the reader's experience of arousal and orgasm. If in 1971 the readers discovered the clitoris as if it were an unknown organ, in 1976 they found an organ that itself was divided into a series of parts, each of them named and articulated into a new morphology, crura singular crus, so that the reader can move from the surface of the body to its interior. In the 1976 Our Bodies, Ourselves, the clitoris is not only gloriously isolated, but capable of both being and non-being. It is palpable and visible, but also hidden and known only through textual mediation. This text draws on a particularly rhetorical imagination. The body is reorganized through the agency of Masters and Johnson's popularized scientific discourse. In Our Bodies, Ourselves, political difficulties are translated into highly overdetermined images that promise a relation of the investigator to the self that is both scientifically detached and erotically engaged. The book and the body become representations of each other, alternate forms of a promise of simultaneous connection and autonomy. While the collective proposed anatomical investigation as a search for integration and wholeness, the text that they actually produced was an ingenious performance that prompted women to redraw the boundaries that divided and split the female self. Women who had been caught in the specular act of at once performing femininity and savagely rejecting this performance were offered a new way of viewing the self. Self-regard would not be a matter of accepting or rejecting body parts, each of which was problematic, but of investigating the body, moving from visible to invisible, and of simultaneously experiencing the body as a site of pleasure, arousal, and knowledge, which were not distinguished from each other. The woman who learned from our bodies ourselves was presumably released from her constant review of her own body. Instead, she went into her body as an investigator. Like an early modern anatomist, and I sort of want you to recall the pictures you've seen, say the frontispiece of Vesalius, where the anatomist stands in front of the body but with a book. Like that anatomist, the reader of Our Bodies Ourselves stands before the body with a book by her side. Her experience of corporeality is textually mediated. When it succeeded, that text realigned the woman's experience of her body, allowed her to understand the body as a whole while she experienced it as divided. Anew, Our Bodies Ourselves offered, as one of its most consequential gifts, a new way of knowing and feeling pleasure in the body for a new generation. Thanks very much.
Thank you. That was a wonderful description. I have to tell you that in 1973, I was a freshman at the University of Virginia, and this book came out, and it was passed around our dorm, and we all got out our flashlights and our mirrors, and spent a lot of time trying to find our cervixes, okay, or cervices, depending on how we're supposed to say it. And unfortunately, I was, off at medical school by the time the clitoris came around. But what I wanted to do was sort of talk a little bit about how this has shaped us, because as a physician in obstetrics and gynecology, a lot has come out of this movement. So, for example, when doing OB, the Lamaze movement, the whole deliver naturally, how to breathe your way through labor, not needing pain medication is an outgrowth of this. As a gynecologist, the cervix comes back because women wanted to decide, if I'm having a hysterectomy, should I have my cervix left in or taken out? So they wanted to become a part of some of those decisions. And now that I'm a menopause specialist, which is what I do, we now have books as we age, which have been great. As you can see, one is Our Bodies Ourselves Menopause, which is interestingly written by providers and also women, and so it comes as a combination of some evidence-based medicine along with some practical common sense, all in this activist field that Sue has talked about. And then we have one about aging, because certainly people who are baby boomers and have gone through Lamaze and decision-making about surgery also want to know how to age more appropriately or differently. So in our practice at the Midlife Health Center, we've really taken this approach and said, let's give evidence-based information to women. Let's look at them as whole pieces, and let's involve them in the decision. So it's not the patient making the decision, it's not the doctor making the decision, it's really shared decision-making together with a lot of education and counseling. And I listed in your handout some common myths, and when they came out with the menopause book, I sent 10 myths forward, and they used some of them, and then Catherine and I sat down and really thought, what are some of the myths that are out there? And I'm only going to comment on a few of them, but menopause is not the beginning of the end. It's a normal time. You've heard about power surges and postmenopausal zest, and women talk about that, whereas 15 years ago, you didn't tell anybody you were having a hot flash. And if you turned red at the dinner table, it was, not because you were having a hot flash. I'm going to talk about the next two, but, a comment, sex ends when you stop having periods. What about sexuality as women age? What about libido? There's a lot we still don't know. And, whereas if for men you think it's an on-off switch, for women, think about sitting in the pilot's chair and that big skewer in front of you with all those switches, that's libido for women. And so we're still trying to figure out how to help women as they age. Number 6, if no one in your family has breast cancer, you won't get it. That myth still abounds. People still believe that because nobody in my family has had breast cancer, I can't get it. This is something our bodies ourselves would tell you is not true. Women are less likely to die from heart disease than men until menopause, yes, but once you go through menopause, the risk approaches that of men. And number 8, only women under 40 have to worry about pregnancy or sexually transmitted diseases. Well, who knows what the second highest unintended pregnancy rate is? It's in the 40s. And what about people who become widowed or divorced? We do have to talk about sexually transmitted diseases, so it is an issue. And number 9, of course, how many people in here exercise regularly? Yes, and you're not all in your 20s and 30s, so you've proven that one. And of course, we know that senility is not inevitable. I wanted to look at the myth about osteoporosis. When I was a student, medical student, we really did think that as you aged, you became stooped, and that was a normal part of the aging process. But now we know that if the patient at age 50 on my left, this is the same woman 25 years later. But I hope that through the care that we now give to address whether or not you're at risk for bone loss and fracture, we can prevent them from becoming the woman on the right. And so that to grow old is not to become stooped. That's what yoga and Tai Chi is all about. And then one piece that sort of was a media moment was in 2002 when flashing across the TV screen, estrogen causes breast cancer, estrogen causes heart disease and dementia, and estrogen became a poison. And women didn't trust their healthcare providers, and they were very concerned about what to do and how to handle the menopausal practice. And into that, and you might recognize, came bioidentical hormones, because if it didn't come from the pharmacy, if it wasn't FDA approved, it must be better and safer. And so even on Oprah this year, we've had Suzanne Summers touting the fact that there's a way to take hormones naturally without any risks. And what I would tell you is that a hormone is a hormone, and we have to worry about risk of breast cancer, risk of uterine cancer, and benefits for each and every woman, regardless of whether it comes as a prescription or from a compounding pharmacy. But this is where our bodies ourselves helps us, because it empowers women to seek knowledge. And my job is to say, make sure that you get that knowledge from somebody that's evidence-based, that's looking at the literature, not where your expert might be an anthropologist, or where it sounds good, but there's really not any backup for it. And of course, the good news in 2007, which wasn't a media event, is that actually for menopausal women, we can give hormones safely. It actually has less mortality and less heart events. And again, if you look in our bodies ourselves, you'll find that this information is there, that we can treat women. So I want to close with 2 pictures. This to me is a continuation of where we've come from books like Our Bodies Ourselves. It's not the years, it's the life in the years. And lastly, how do we grow old without actually getting old? And I know that in these books will be the answers. Thank you.
When Marcia invited me to come today, I looked at my copy of Our Bodies Ourselves, which also dates me because it was back in the glorious 1970s era. And I began to think about what was going on in the 70s and how truly remarkable this book was. When you think about it, people didn't talk about health. People didn't talk about sex. Women's lingerie ads weren't in magazines. I mean, think about the world without Victoria's Secret. We didn't have the internet. I mean, it was a vastly different world than the world we know now, with the proliferation of health information, the discussions about health, sex, our bodies, and ourselves. It was also an era when women's health was not an area of particular concern. It was only about 10 to 15 years later that the scientific community actually recognized that women are not just like men, other than the childbearing function. I mean, most of the people in this room are, well, not most, but many of the people in this room are too young to remember that for a long time, that was the only distinguishing area for women's health. If you said to somebody, can I talk to somebody who knows something about women's health, the only person whose name would come up on the list would be an OBGYN. Now when you talk about women's health, we talk about a lot of different medical and non-medical people who are interested in improving women's health and women's well-being. The book gave a message to women, as Sue alluded to, that your body is important, that you can be an active participant in your health, in taking care of yourself, and also that you could be an active participant in your health care, that it was okay to ask questions about your body. It was okay to talk to your doctor, that it wasn't necessarily a one-way communication from the doctor to the patient. And I think that is probably one of the most remarkable things about the book. I mean, Marcia referred to it as an owner's manual, and it gave women the tool to understand what this machinery, this mechanism was about. And despite Joanne's concern about patients coming in with a lot of questions and misinformation, I think that one of the true benefits of this book was that it began to change the way in which women were actively engaged in their own health and in taking care of their well-being and in approaching their physicians and other healthcare providers. On the other hand, I think this book had a lot of limitations that we have to recognize, and limitations that still are abundant in the way we deal with information about women's health and how we present it and what the scope of that information is. This book was for highly motivated, highly literate women. If you look at it, anyone who knows about literacy, I mean, it is chock full of words and Latin words. It is not for the average female reader who wants to learn about her health. If we're going to make information usable for women, if we're really going to give them an active role in taking care of their health and their well-being, and give them the tools to have conversations with their physicians, the information has to be readily available to them and understandable to them. We need to think about how motivated people are in seeking out information. Think about the internet. People who look for information on the internet are motivated and have to have the skills and the tools to look at information and hopefully have the skills to understand what is reliable information. So while Our Bodies, Ourselves was an owner's manual, not everybody can use the owner's manual. Not everybody's interested in using an owner's manual. And we have to make sure that those women who are not necessarily motivated, not necessarily all that interested, who are not capable of searching for information, that we get them information that they can use in a way that they can understand it and incorporate it into their daily lives, and then also use it when they do seek health care. Women's Health Virginia did a survey about half a dozen years ago of adult women in Virginia. And we found that about 20% of them were not satisfied with the health information that they got. They were either very dissatisfied or somewhat dissatisfied. And about a quarter were dissatisfied as to how easy the information was to find or how easy it was to understand. Now, some people might say, well, it was only a quarter, only a fifth, but think about that. If 20 to 25% of the women feel that there is an information gap that they're not satisfied about, there is a gap that we as the medical community, as many of the people in this room are, and people who are concerned about women's health, that we have to deal with that information whole. We also learned that while many women are very satisfied getting information in written form, like Our Bodies, Ourselves, there are many women who don't want to read about it. And when we looked at the demographics, the people who were least satisfied with reading about health information were women under 25, women over 55, the uninsured, and women who had a high school education or less. Well, again, it's the educated, motivated people who are using information, and again, this is gap that I think we all have to deal with if we're going to give women the tools they need to take care of themselves and be effective healthcare consumers. I think that there are two key factors. One is helping women, and it's all people, but since we're focusing on women, but helping people know what is reliable information and where they can find the information that suits their needs, that's understandable to them, that it's not all this highly literate, dense kind of information. We have to be better at explaining in simple terms what health issues are about. And I think that in medical, as I said, the medical community, healthcare providers in particular, doctors in particular, have to step up to the plate and recognize that they are an important source of information. Our survey showed that doctors and specialists are the most trusted sources of information. And yet I know that many doctors don't see themselves as information disseminators. They see themselves as diagnosticians and clinicians. And so I think we have to begin to think about how those tools of information can be made available, making doctors part of the conversation, whether they disseminate the information or just put their thumbprint on the information that a nurse or a health educator can provide. And we have to give those doctors who do want to take the time to actually have the conversations with their patients, like Joanne talked about with the Midlife Health Center. Because sometimes it's not the pill or the procedure, but it's that extra 5 minutes of conversation that makes a woman feel that her provider cares about her. And the outcomes, when we look at studies about patient satisfaction, usually the outcomes in treatment are better when the patient satisfaction is higher. The second limitation of our bodies or ourselves that I want to address is going to be a 2-sentence discussion. Sue talked extensively about how this book focused on reproductive and sexual health. And I mentioned earlier that women's health is much broader than just reproductive and sexual health. I think we have to recognize that not only it's broader than reproductive and sexual issues, but it's also broader than just the medical diagnostic issues. That women's health and women's wellness is affected by a lot of non-medical issues, that her actual health status can be affected by other factors in her life. Her economics, her education, her job, the environment in which she lives. And if we're going to truly address women's health and improve women's health status, we need to think about this multifaceted, the multifaceted number of issues that affect women's health and well-being. And only then will we really give women the tools to care for themselves and be the healthcare consumers who can be active participants in their health care. Thank you.
Thank you so much to all three of you. Thanks to all three of you for wonderful presentations. We have a few minutes for audience comments and questions, and I'll bring the microphone to you. And please identify yourself when you ask your question.
My name is Bernard Williams. Thank you for the great presentations. It takes me back to the 60s and 70s. And at that time I was a practicing physician. And I in fact gave a copy of the 73 edition of Our Bodies, Ourselves to my new wife, which I think she appreciated. I remember during that time, that I think it was in the mid-70s or so, that there seemed to be an idea floating around, which I thought came out of the women's movement. And it was about whether or not menopause really existed. And I wondered if you, Dr. Wells, could comment on the politics and the discussions that occurred in the movement about menopause.
That's a great question, and I'm happy to do that. A lot of questions were kind of up for grabs in the mid-70s. Women in the women's health movement didn't believe that any piece of received knowledge could be taken for granted. Within the Boston Women's Health Book Collective, there was a general agreement that there was such a thing as menopause. But the only piece of medical research that they ever did as a group, independently, was the menopause survey. They got a lot of money from Simon & Schuster for the 1973 edition, and they decided to give, somebody suggested that they save some, but that would be so capitalist. So they donated a lot of it to clinics. They paid themselves, And then they commissioned a survey where they asked women about their experience of menopause, because they figured that only women who'd had trouble in menopause would have gone to their doctors. And so there was maybe this big universe of women for whom it was all fun or something, you know? And they collected the surveys, which are still in their archive at the Schlesinger collection, although very, very masked at this point, and published the results in the 1976 Our Bodies, Ourselves, and found that for many women, menopause was not a particularly difficult time. Very soon after that, they began to do work around menopause and women's midlife health issues. That really was published in the 1985 Our Bodies, Ourselves. There were some strange health practices circulating in the early 80s, which the collective found information on but didn't generally popularize. I mean, maybe the most doubtful thing they ever popularized was the astrological birth control in 1973. That was a mistake. And they checked it out in 76. They said it didn't work.
Thank you for this really historical perspective, which, having been a reader of the original Our Bodies, Ourselves, this is really interesting to see how it all fits together. And I wanted to address Dr. Bender's comment about the other aspects to consider: economic, cultural, social, and also psychological. My name is Phyllis Katshiris. I'm a clinical psychologist. And I remember in looking back over the book again, there's some psychological, discussion in the book, but it seems to me that we need to be working together more with all the different disciplines and getting this word out to more and more people. And I wonder if the collective or there's any work being done on that area.
Right now, that isn't a central focus for the collective. It was a really critical issue in 1985. There was a very important and influential member of the collective, Norma Swenson, whose view of psychological health was really heavily shaped by Ivan Ilyich and kind of anti-psychological sort of perspective. There was also a member of the collective, equally influential, equally stubborn and articulate, Miriam Hawley, who was making her living as a therapist. So the result was a psychotherapy chapter in 1985, which began by talking about how psychotherapy was kind of like rape, then went on and talked about how to choose a psychotherapist, and kind of split the difference at the end. I don't think they ever really got past that. It has always been an area of conflict and negotiation within the collective.
Well, I'm afraid we're having a conflict and negotiation with time because our time is up. But again, I'd like to thank our three presenters today and for this very illuminating discussion and maybe a bit of a time trip back for many in the audience. I would like to thank especially our partners in today's program, the History of the Health Sciences Lecture Series, the Midlife Health Center, and Women's Health Virginia. Please join us next week. We have Lynn Eckert here from Harvard. She's a physician writer. She'll be giving the Moore Lecture at the School of Medicine in conjunction with the Virginia Festival of the Book. And again, thank you all for being here. And please, a hand for our speakers.